Today's lecture is idiopathic Parkinson disease. Parkinson disease is part of movement disorders which are presented with wide range of symptoms. Most movement disorders are characterized clinically. Either it is rhythmic, such as tremor in this patient as resting tremor, posture tremor, intention tremor, or flapping tremor. Or it is non-rhythmic movement, such as rapid movement in this type of chorea, or unilateral movement, which is hemipalsmas, which both are non-stereotype, or it is slow movement like athetosis, which is rhythmic movement in distal part of the limb, or dystonia, which is fixed posture or combination of movements such as dystonia and athetosis, and sometimes involuntary control movement, which are tic. Movement disorder, either genetic or acquired, and the most important of them is Parkinson disease. Parkinson disease is part of a clinical syndrome which is called Parkinsonism that covers several conditions, and they are similar in symptoms such as slowness of movement, increased tone, tremor, and problem with walking. The causes of Parkinsonism, mainly idiopathic Parkinson disease in 80% of patients, and cerebrovascular disease, drug-induced Parkinsonism, genetic causes, anoxic brain injury, and other degenerative disease. Our interest today is idiopathic Parkinson disease because it is affecting 5 to 6 millions of persons worldwide, and it is the second commonest neurodegenerative disorder, followed Alzheimer's disease. It is characterized primarily by slowness of movement as bradykinesia, increased tone, rigidity, tremor, loss of postural reflexes, and other non-motor symptoms including cognitive impairment, depression, and anxiety, which are occur late. Epidemiologically, age has a critical influences regarding prevalence. In 100,000 persons in general population, about 180 have Parkinson's disease, while above 80 years of age, about 300 to 500 persons having Parkinson's disease. The average age of onset is about 60 years, and fewer than 5% of patients presented under the age of 40 years. The incidence of Parkinson's disease is more in male. It is attributed to different environmental exposure and sex chromosome and the influence of estrogen in female. Parkinson's disease is caused by a combination of gene, environmental, and lifestyle influences. Approximately 15 to 25% of people with Parkinson's disease have a relative with the same disease. Parkinson's disease is more common in white rather than black or Asian. The factors that reduce the risk of Parkinson's disease mainly including coffee and cool intake, while the factor that's causing increase the risk of having Parkinson's disease are mainly constipation, depression and anxiety, head injury, anosmia, rapid eye problem disorder, exposure to pesticide, and genetic. The pathological hallmark of Parkinson's disease are depletion of pigmented dopaminergic neuron in the substantia nigra, and the presence of alpha-synuclein and other protein inclusion in nigral cell called Lewy bodies. Lewy bodies also found in the basal ganglia, brainstem, and cortex and increase with disease progression. To understand Parkinson's disease, we must know what is the nigrostriatal pathway, which is bilateral dopaminergic pathway in the brain. That is, connect the substantia nigra pars compacta in the midbrain with the dorsal striatum. It is dopamine pathway and it is critical in production of movement. Dopaminergic neuron of this pathway release dopamine from axon terminal onto neuron in the striatum. In order to perform voluntary movement, cerebral cortex may be activated by the thalamus. Thalamus under direct inhibition of lobus pallidus interna. For activation of thalamus, lobus pallidus interna must be inhibited. The inhibition of lobus pallidus interna in two different pathways. The direct pathway, which comes from substantia nigra to the putamen, activating the putamen, that is inhibit the lobus pallidus interna, and the indirect pathway, which is inhibitory pathway to the putamen, then inhibitory to the subthalamic nucleus. The activation of subthalamic nucleus in turn activating the lobus pallidus interna, which inhibited the activation of thalamus, leading to inactivation of the cerebral cortex. In Parkinson's disease, because reduced activity of nigrostriatal pathway, the subthalamic nucleus will not inhibit it, and this will have excitatory effect on the lobus pallidus interna, which inhibit the thalamus activity and lead to less excitatory effect on the cerebral cortex, leading to reduction of intended movement in the cerebral cortex, and this gives to the manifestation of Parkinson's disease. These loops are called direct and indirect pathway. The direct pathway will lead to excitation of thalamus and inhibition of lobus pallidus interna, while the inhibitory pathway, which is indirect, involving of inhibition of the thalamus by inhibition of lobus pallidus externa, allowing the disinhibition of lobus pallidus interna through subthalamic nucleus. Parkinson's disease have a wide manifestation, including motor and non-motor. The cardinal motor feature of Parkinson's disease, including bradykinesia, resting tremor, and rigidity, which are the main cardinal manifestation, and may associated with gait disturbance and postural instability. Other motor features include micrographia, mask face, reduced eye blinking, soft voice, dysphagia, and freezing. The onset of Parkinson's disease may be preceded by a prodromal period, in which there is a premotor manifestation preceding the motor manifestation in many years, including constipation, rapid eye movement, behavioral, sleep disturbances, excessive daytime sleep, hyposmia, and depression. The diagnosis of Parkinson's disease usually following the initiation of motor manifestation, which are mainly started by tremor, rigidity, and bradykinesia. The motor symptoms are almost always asymmetric at beginning, will gradually become bilateral with time. The advanced late manifestation, including dysphagia, postural instability, freezing of gait, and fall to the ground. Non-motor manifestation, late manifestation include urinary symptom, orthostatic hypotension, and dementia. And about 80% of patient presentation with resting tremor, which is 3 to 4 hertz. It's typically unilateral, affecting upper limb, jaw, and chin, but not involve the head. In some patients, tremor remain the dominant symptom for many years. It affects the writing, tremulous writing, as in this figure. It affects the usual function of the patient, like fasting bottom. Second type of tremor which can occur in Parkinson's disease is postural tremor, which is occur in about 6 to 8 hertz. It's present immediately on stretching out of the arm. Other causes of postural tremor include psychologic, drug like caffeine or nicotine, alcohol withdrawal, increased metabolism like hypothyroidism, sleep deprivation, and anxiety. The cardinal and fundamental feature of the Parkinson's disease is bradykinesia. There is no diagnosis of Parkinson's disease without bradykinesia, in which there is reduction in speed and amplitude of voluntary movement, leading to increasingly slowness of walking, dressing, and associated with mask face, hypophonia, micrographia, difficulty in tying shoelace or buttoning clothes, and difficulty in rolling over the bed. And this is a sample of the writing of Parkinson's disease patient in micrographia. The third manifestation is rigidity. Rigidity is an increase in tone, can be detected distally by moving the hand. There is an increase in tone in all direction, in all range of movement. We have two types of rigidity. Either it is cogwheel type, when there is superimposed by a tremor, or lead by type, there is no tremor. Rigidity causes stiffness and flexed or stoop posture, in which there is flexion of the neck, flexion of the trunk, flexion of the upper limb, flexion of the lower limb. Because of hypokinesia, rigidity, and the tremor, the gait of Parkinson's disease have a characteristic feature in which it have difficulty in turning, difficulty initiation of movement, have a stoop posture, slow, short stride, shuffling on the ground with absence of hand movement, sometimes associated with postural instability, but it mainly occur late stage. Other non-motor symptoms include anosmia, sensory disturbances, mood disorder, sleep disturbances, autonomic disturbances which occur late, including orthostatic hypotension, gastrointestinal disturbances, mainly constipation, genitourinary disturbances, and sexual dysfunction. Cognitive impairment like dementia or associated dementia mostly impair quality of life of the patient and their carer, and it is estimated dementia occur in frequency of 30 to 80% in Parkinson's disease. Lastly, neuropsychiatric features including anxiety, depression, apathy, hallucination, or psychosis. The diagnosis of Parkinson's disease is mainly clinical because there is no structural imaging abnormality except when there is vascular cause of Parkinsonism. Functional dopaminergic imaging by SPECT or PET is abnormal even in early stages, but it is not specific for Parkinson's disease and does not differentiate between different types of Parkinson's disease, even degenerative Parkinsonism. In young patients, a specific investigation is mandatory to exclude Huntington or Wilson disease. Parkinson's disease management remains symptomatic rather than curative, and until now there is no currently available neuroprotective drug. There is a debate about the initiation of the treatment, whether early or late. The levodopa has remained the most effective treatment until now. The list of drugs that can be useful in Parkinson's disease include first levodopa, dopamine agonist, anticholinergic, monoamine oxidase inhibitor, catechol or methyltransferase, and amantadine, and lastly adenosine A2 antagonist, while surgical intervention are reserved for specific situations. Parkinson's disease is caused by reduction of dopamine in presynaptic terminal in nigrostriatal pathway. So the main treatment is providing dopamine by the levodopa. Levodopa is a precursor of dopamine, which be transmitted to dopamine by tyrosine in the nigrostriatal pathway. But most of levodopa will convert it to dopamine outside the central nervous system as periphery. For preserving levodopa to the central nervous system and preventing its conversion peripherally, it must be combined with either benztrazine or carbidopa or COMT inhibitor. Another alternative treatment is activation of postsynaptic dopamine receptor directly by dopamine agonist, or increase the availability of dopamine by preventing breakdown of extra dopamine in the synapses by seleginine, prasagiline. Levodopa is the first treatment for Parkinson's disease. Levodopa is most effective for relieving akinesia and rigidity, and it is less satisfactory for treating tremor, postural instability, and freezing, and have no effect on non-motor symptoms. Failure of treatment of akinesia and rigidity by the dose of about 1000 milligram per day prompt the consideration of the diagnosis. Levodopa is a precursor of dopamine. It converted to dopamine in the central nervous system. It is administered orally. 90% is decarboxylated to dopamine peripherally in the GI tract or blood vessel, which is responsible for adverse effect. To avoid peripheral decarboxylation, it's combined with DOPA decarboxylase inhibitor, which are not crossing the blood-brain barrier, so it is not affecting the central dopamine work. So it is available in combination, either in form of cinemate, which is carbidopa plus levodopa, or medobar, which is benztrazine and levodopa. The early adverse effect of levodopa include postural hypotension, nausea, and vomiting, which may be offset by domperidone. Levodopa may exacerbate or trigger hallucination and abnormal levodopa-seeking behavior like gambling and overshopping. Levodopa-induced involuntary movement would tend to occur at the time of the peak of dose of the levodopa in form of chorea or dystonic movement, as in this example. These are a dyskinesia. In the early stage of Parkinson's disease, levodopa action will be prolonged for long time, so have long action of duration, and in later stage have shorter action of duration with reduced response threshold, and may be associated with the dyskinesia, while in the later stages it have shorter half-life and shorter time of action with associated dyskinesia, and this is called levodopa-induced motor complication. It is progressively increased with time. The loss of benefit of levodopa is known as wearing off effect while on episode when the drug is working, off episode when Parkinsonian feature return, and involuntary movement known as dyskinesia. Motor fluctuation of levodopa can be improved by continuous intestinal infusion of levodopa carbidopa by intestinal gel, or addition of dopamine agonist, or alternatively using deep brain stimulation implantation. The second medication can be used as dopamine receptor agonist. It is less effective than levodopa and in relieving Parkinsonism, and have more adverse effects like nausea, vomiting, disorientation, hallucination, and impulse control disorder. We have two types, either ergot-derived or non-ergot-derived. The ergot-derived agonists have no longer recommended because rare serious fibrotic effect. Dopamine receptor agonists can be used as monotherapy in early stages, but the evidence suggests that their usefulness as initial monotherapy is short-lasting or used as adjunctive therapy with levodopa. Other medications are used for overcome the motor complication of levodopa, including the monooxidase B inhibitor, which increase the availability of dopamine for use again, including selegiline and razigeline. They are usually well tolerated with mild to moderate effect. Second is catechol or methyltransferase inhibitor, including entacapone and tolcapone. COMT inhibitor is involved in peripheral breakdown of levodopa, prolonging the levodopa half-life and making more levodopa available for transport across the blood-brain barrier over a longer period. Entacapone has a modest effect and is most useful for early wearing off. It is available either as single or in combination with levodopa. Tolcapone is less used because of rare but serious hepatotoxicity. Amantadine has a mild and short-lived effect on bradykinesia and is rarely used unless patients are unable to tolerate other medication. It is more commonly employed as treatment for levodopa-induced dyskinesia. Its adverse effects include levator reticularis, peripheral edema, delirium, and other anticholinergic effects. Anticholinergic like trihexyphenidyl and benztropine, mainly used for patients who have disability due to tremor that is not adequately controlled with dopaminergic medication. Their adverse effects include dry mouth, blurred vision, constipation, urinary retention, and delirium and hallucination. Adenosine A2A antagonists are a combination therapy with carbidopa and levodopa for reducing of time by about 30 to 60 minutes per day without worsening dyskinesia. Lastly, surgical intervention is usually reserved for individual with medically refractory tremor or motor fluctuation. They can benefit from brain deep stimulation. Small intestinal tube insertion to deliver a gel formulation of carbidopa and levodopa for overcome the levodopa motor fluctuation. Occupational and speech therapy is important for maintaining normal life for the patient.
Subthalamic nucleus